with the laptop problems, so it cannot connecting to the internet. So you can make the these the things live, please. Team, can you hear me? Okay. So we will have another 2 minutes or 3 minutes, then we will start, inshallah. I will try to share my screen just to see if my presentation is shared. Okay. Okay, you can see, anyone can comment?
Yeah, we can see it clearly.
Okay, thank you. Another 1 minute, inshallah, we'll start. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Dear colleagues and friends, welcome to another meetings of NEOM weekly meeting. And today we are having webinars about peripheral retinal dystrophies, episode 6 of Master Medical Retina from A to Z. Today we have all my real friends and good friends and dear friends. I have my dear friend Dr. Safwan Al-Bayati in the panelist, and he is an ophthalmologist, consultant ophthalmologist, the medical director and phaco-refractive surgeon, cataract LASIK, pituitary surgeon in Nubian Center in Dubai. And also my dear friend, Dr. Ahmed Al-Khashab, he's an ophthalmology consultant, head of pituitary unit and medical director of Eye Consultant Center, Dubai, Healthcare City, Dubai. My dear friend, also speaker today, Dr. Prasan Rao, he is an FRCS, and he is MBBS Medical Director, Specialist Ophthalmologist, and Pituitary Surgeon, Medcare Eye Center, Dubai. First of all, I would like to thank Jamjoom for sponsoring this event. And I will today have the talk in the beginning of the first part of this session. And then we will have my dear friend, Dr. Prasan, he will talk about peripheral retinal dystrophies as an episode 6 of Master Medical Retina from A to Z. So my talks, it will be about the month of dry eye. I will share my screen. Dry eye awareness month of this month. Sorry. Dry eyes awareness, and this July is recognized as a month of the dry eye for awareness. And I'm going to just to highlight about certain points before I start give my talk about the dry eye itself. This is the dry eye awareness is, as they are mentioned, don't ignore your dry eye symptoms. And there is actually a study done in UAE with different colleagues, and they have concluded from that the prevalence of dry eye in Dubai around 62. The majority of participants had severe dry eye symptoms, and more commonly among females and users of contact lenses. This is the study done in UAE. Another study was done in Saudi Arabia regarding also the dry eye, a month of dry eye, this one, and about on doing the screening, they have concluded that dry eye are highly prevalent among adult population and females, persons more than 55 years of age, smokers, and or diabetic, and were associated with more dry eye syndrome. So this is just a highlight about the month of dry eye. So now if you want to go to my real talks, which is about the dry eye syndrome definition, I think dry eye, most of us, we are talking a lot about dry eye. I know maybe most of you, they get fed up of talking about dry eye. So I will be very brief, and I will just highlight about certain points. There is a lot to talk about dry eye actually, and it is a real disease that we are having a lot of patients. They are coming to our clinic. Sometimes we are missing some patients, and we are not able to distinguish between if they are dry eye or another disease like allergy or something like that. So yes, it is a boring maybe topic for most of us, but it is an important at the same time. So dry eye definition, I will highlight about those. They are highlighted colors, multifactorials, and this disease. So it's a multifactorial disease, and that disease affecting ocular surface disease and result in damage to ocular surface. And this one is accompanied by increased osmolarity. So we are having different things that affecting the dry eye. And there is a part of the dry eye is inflammation. So there is damage, apoptosis, there is increase in the osmolarity, there is inflammation, and also, sorry?
Yes.
Apoptosis, yeah. Apoptosis, inflammation, and also there is a neurogenic. Also, they are adding to the definition lastly that there is some of neurogenic effect in the dry eye syndrome. So if we want to go to classification, also there is a lot of different type of classification, but if you are concentrated, it could be due a mechanism, if you are thinking what is the mechanism, or etiology, which is the most type we are depending on that, or most of us we are talking about etiology, and sometimes we are classified the dry eye in according to the severity of disease. From the etiological classifications, as you know, this is the one, as I told you, is the etiological classification is the most common we are used. It can be an aqueous deficiency, evaporated, one of that disease. The etiological classification can be aqueous tear deficiency, or lipid deficiency, or mucin deficiency. It can be impaired eyelid functions due to eyelid dysfunctions or problem, or epitheliopathies. Questions now for us, of all of us. What are the percentage or of dry eye patients that we are seeing in our clinic? So I just keep this number, and maybe it varies from one to another one. I don't know, then we can discuss this one between us after we finish. None, I don't think so. 0 to 25, I don't think so. It could be 25 to 50 for some other, it can reach up to 50 to 70%. So this one, it varies. There is no specific answer for this one, but it is high number. So let us discuss this later on. The prevalence of dry eye disease also is average age of the dry eye patient is 54. Most are women. This is actually, it can be, we can say it is something before, but now even for the young generations and the people, even the young children and young adults who are using smartphone, laptops, they are having a lot of dry eye, not as before we used to say only in the old age. Dry eye syndrome affects 75% of people over the age of 65. This is something before we know. Common reason for ophthalmologist visit, as we mentioned earlier, according to that. Prevalence rates ranging from 7 to 33% from many different studies they have done in different places. So it's a common overlooked problem. We need to mention that it's 38 to 75% of patients requesting LASIK. This is regarding the related of the dry eye with refractive surgery, actually. So 38 to 75% of patients requesting LASIK have symptoms of dry eye. Maybe it can be changed. That's what I have it with me. Immediately after LASIK, most of them, they are going to dry eye, 95% of patients. And 1 month after the LASIK, 60% of the patients report some dry eye symptoms. I want to highlight about this point because I want to discuss this point also with Dr. Safwan, because he is doing a refractive surgery a lot. So, and also, you know, it's something that is a surgery now is most popular between most of our people in the young age. Dry eye reason for a patient dissatisfactions. 30% of patient referrals to the tertiary care center have dry eyes. There is a 2 studies suggesting this one. Dry is a common among cataract surgery population, about 20%. Dry eye affect IOL calculation and affect visual outcomes and recovery times. Refractive surgery, also dry is the most common complication of LASIK. Virtually all patients experience dry eye after LASIK, as we mentioned earlier. 6 months after LASIK, this is another important, approximately 20% patients continue to report dry eye. Other than that, there is some study demonstrated that 30 to 50% of LASIK patients experience chronic dry eye persisting beyond 1 year after surgery. Dry eye, like after cataract surgery, you know, there is in cataract surgery in day 1 is less. This is just a scoring. In day 1, you can see it's a high score, then it was decreasing till the day of 16. So within the 7 days after the cataract surgery, you can find there is a high score of dry eye due to or after cataract surgery. Dry affect the vision, yes, affecting the vision, especially some people, they are reporting in night driving, affecting in 33%, 28% affecting the reading, and those they are using also computer in 26, and watching TV in 17%. So it have many effects in our life. Diagnostic of dry eye, it can be ocular surface disease or something. This one we need just to go. There is many things, I mean, to go through the diagnosis, but it can be a history, it can be a symptoms taking from them, then examination, slit lamp examination, then we have to do osmolarity, break up time, Schirmer test, staining, and many other things that can be used to diagnose of dry eye. What is the objective of assessment of dry eye? The most important, also there is an osmolarity, has the highest correlation coefficient to disease severity, followed by conjunctival staining, corneal staining, ocular surface inflammation, Meibomian score, or to break up times, and Schirmer test. So osmolarity, one of the most important factors that play a role in dry eye syndrome. Also, we have not to forget about Meibomian gland. There is a specific Meibomian gland evaluation, symptomatic, asymptomatic. Also, we don't not to forget the inflammation. Inflammation, as we mentioned in the definition of the dry eye, it's a very important role. And now we are having also a test to do that. Even without testing, according to, we are using sometimes only the clinical judgment, and we found that we are needed to give a treatment for anti-inflammatory drugs that available in the market now, either cyclosporine or Zedra, or sometimes we are using before steroid. So what are the principle of treatment? Principle of treatment, we have to treat the symptoms. So the patient's very important for him to treat his symptoms. And also we have to look for the causes behind that, because there is a lot of causes as we mentioned earlier. And then we have to treat the complication whenever the dry eye has affect the eye. So the treatment goals, establish diagnosis. This is very important. We need the most important to concentrate, and this maybe slide, this is the most important slide. Establish the diagnosis of dry eye, differentiated from other causes of irritation and redness. Because sometimes we can give a treatment and it is not really a dry eye, he can have something else. Or identify the causes of dry eye, especially when sometimes we are having a history of people, they are taking medication. It could be only a medication giving him, or give a causes of dry eye, especially for those medication in young age when they are used for acne vulgaris treatment. Establish appropriate therapy, and this we are going to highlight this point later on, how to establish the appropriate therapy. Relieve the discomfort, because this is the most important for the patient. Also, we need to prevent the complications such as loss of visual function, infection, and structural damage. Also, this is one of the last one is one sometimes we are forgetting, educate and involve the patient in the management of his disease, of this disease. This is very important because sometimes the patient, they don't know if they need to continue on drugs. Some of them, they are just taking for 1 month and they come back after they are not improving. They tell, because you have to explain it can be a long process and he need to take this for a long period of time. It could be long life with him, and accordingly, and if he take it properly or not, and so on. And he have to be patient, because this disease is need a long time journey with the patient and the doctor himself. So the mainstay of current dry eye management is tear replacement therapy. I think this is, we are still on this era. I mean, this is the main. There is another things, but it could be very specialized to a certain cases. So what are the ideal tear substitutes? The ideal, it should be the viscosity. Viscous, it should be not so viscous. It should be less viscosity. It should be hypoosmolar. We said in higher osmolar, it will be a problem. pH value around 7. Thioxotropy. This one is, that mean, we mean there is we have to shake the bottles and it will become fluid, and then it will be after a while become again solid. This one it's a good for indicating for the good medications. One of the most important now, also preservative free, not only in the dry eye, most of treatments or drops used in the eye. Also contact lenses tolerance, so they can use and these drops with contact lens. Also the most important, also satisfactions. This is a triangle talking about lubricants. We have to have electrolytes, we have to have a preservative free, osmolarity in proper time, then we will have a clarity, no blurring for the patients, stability, lasting effect, fewer applications, and lubrication symptoms relief, improve quality of the life, ocular surface healthy. This will lead to really patient satisfactions and improvements in the quality of life of the patients. How to choose the right brand for the right patients. In the treatment of dry eye, frequent installation of drop is required, and this is we don't want a high frequent. As less as we can get less frequent, then it is better. We should choose a drops which is effective and least toxic. We should choose the one where preservative is there, not represent or not present, or disappear soon after we install that drugs in the eye. So, and the best is, I think now these days, most of our type of drops we are using preservative free. Recommendation for treatment, we are having four level for treatment of dry eye. Level 1, this one, the first one, treatment consists of the following. First, as we mentioned, and it's very important, I am repeating this, education, environmental or dietary modifications. This is the first things to be done. Elimination of the offending systemic medications, if he is using some medications or he is using glaucoma or any systemic medications, I mean ocular or systemic medication. Artificial tear substitute like gel ointment and eyelid therapy. So this is the level 1 recommendation for the treatment. When I think it could be the mild to moderate types of dry eye. If level 1, sorry, is inadequate, so we have to go to a level 2. This one we will add on the top what we have done in the level 1. Non-preservative artificial tear substitutes is more important here. Anti-inflammatory agent. Tetracycline sometimes may need it for mebomyelitis or rosacea, and sometimes we go to punctal blood. So if level 2 also inadequate, we will have to go to a level 3, and we will add another things. We can go to autologous serum, contact lenses, or permanent punctal occlusion. Lastly, if the level 3 is treatment inadequate, we have to go to something extreme, little bit administration of systemic anti-inflammatory or tarsorrhaphy. To summarize what we have mentioned earlier, that dry eye is a multifactorial. It have a comprehensive assessment we have to do. We have to know the severity level of the dry eye. Then we have to tailor the therapeutic approach, either monotherapy, combination therapy, immunomodalities, or surgical intervention. Lastly, we want to do this thing, keep blinking. Don't forget to keep reminding your patient blinking frequently and completely. And also the what we call the is 20/20 advice. So he have to close every now and then, look for a far point, and so on. And by that, I would like to thank you for, and I'm ready for any question from my dear colleagues here or anyone to send his questions. Thank you very much, and see you in 4th MIOM Annual Conference. It will be on 14 to 16 October, and you can follow us in our website, www.miomacademy.com, or Facebook MIOM Academy, or YouTube channel MIOM Academy, and also we are available in LinkedIn. Thank you very much.
Thank you, Muhammad.
Yes.
So I think that when we are talking about dry eye, we need to put it in this sequences, and that's very important sequences. The inflammation is the beginning. The immune synapse is the start. And when immune synapse started, then hyperosmolarity, and because of the hyperosmolarity, apoptosis, and then here we will lose the content that produce the product of the tear. So we will lose the goblet cell, and we will have GDC, and then we will have an inflammation to the lacrimal gland. When we are understanding these sequences, the treatment will be much easier. And second comment. Now, post-refractive surgery, you said that we need to see what's the percentage. The type of the refractive surgery is very important here. And trans-PRK is less than the other. And behind it, the trans-PRK and SMILE, now they have the less dry eye, the LASIK in all its content, whether femto or mechanical, they have the highest degree or a percentage of the dry eye, that it might reach in the first week or second week, maybe more than 95. The sequences that it continued to in the LASIK, definitely more than 3 months. It might lead to the chronicity, as you said, 1 year, but in trans-PRK or in PRK or in SMILE, it might not reach up to 1 month. Now, second things, the important issues and steps in the treatment. When we are choosing the artificial tear, what's the content of these artificial tear? Because you didn't mention anything related to the content, and that's one of the important issues for us as an ophthalmologist when we are deciding to use this type that having hyaluronic acid, or the other type that having hyaluronic acid plus carbomere or methylcellulose plus a lipid. That depends on the situation of the patient. So when we are saying that it's crucial to have the hyperosmolarity, in my opinion. No, it's crucial to have the breakup time, because the breakup time show you that we have a lack of mucin and the meibomian content. And according to that, if those they have breakup time less than 3, for example, and you will use hyaluronic acid only, you will not get any benefit. So as you said, the relief of the patient immediately is one of the important issues that patient need. So patient, depending on a Schirmer test only, 5 or 7 or 8, and then we will give him only hyaluronic, and the breakup time was less than 3, this patient 100% he will not be comfortable. But this patient, precisely when the breakup time less than 10, he need a content like a carbamide or methylcellulose to change the surface of the cornea from hydrophobic to hydrophilic in a way that the tearing can mix, and that's that mimic the action of the mucin secretion of the goblet cell that undergo apoptosis. Finally,
I think, Doctor, okay, sorry, yeah.
Finally, the anti-inflammation here, it's the long treating, but not an immediate solving of the patient problem. That's why the main issues with the use of anti-inflammatory is that the doctors goes directly to the wrong drop and start the anti-inflammatory, where this anti-inflammatory, whatever the type, it will be very irritant to those patients. That's why they will not accept it. They will go through, but steroid is easy use and without irritation, so they will easily use the steroid. That's my comment.
Thank you, Dr. Safwan. I think it's very difficult to talk about dry eye in 15 minutes about everything. That's why I select only certain point. I know we need to highlight the anti-inflammatory. We need to go step by step on the treatment, different type of molecules. But I didn't go to molecules because it will take a lot of time if we will go on through. But you already highlight most of the point that I didn't mention. If there is any other comments from Dr. Ahmed or Dr. Prasan.
No, excellent. You covered it well, and I think even the comments of Dr. Safwan, I agree with them. They are very clear.
Prasan?
I concur with Dr. Ahmed, actually. So, Dr. Amri, your talk was excellent. You in your 15 minutes, I think you did a very comprehensive description of dry eye and the treatment, and Dr. Safwan elaborated to how the patients need to be evaluated and what are the appropriate medications. So thank you very much.
Thank you very much. I think only there is a comment from I was waiting for you to elaborate on that, which is some of my colleague Ashraf Awada. He said he thinks that 80% of the patients can be attending our clinic. It can have a dry eye. And also another comment, sometimes some ophthalmologists treat dry eye as allergies. If there is any, Dr. Safwan, if you want to comment about these things.
Now, for sure that all our patients should have the simple assessment when they are complaining from the general sign and symptoms related to or a share between the allergy and the dry eye. So patients, they are coming with the redness or without, and a foreign body sensation. And when we start as a diagnostic, simple diagnostic tool from the Schirmer to the breakup time, you can discover that it's in this way or in that way. So allergy, the patient will be present with all these elements. The Schirmer is full or more because the tearing is increased, and the breakup time is normal, and those patients, we will treat them as an allergy. Otherwise, when we have less, and then we will go to the osmolarity and it's high, it may be mixed between both, because allergy at the end is an inflammatory process, can lead to apoptosis and any degree of a dry eye.
Okay, Dr. Safwan, lastly, inflammatory cause is usually not the majority cause. This is a comment from our colleagues here, and the simple dry eye due to environmental or smartphone use. I think we are all agree, and also you mentioned that. Yeah. There is another point. What do you mean by preservative free, Dr. Safwan?
Preservative-free is a preservative-free, and we don't have all these component of the main component benzalkonium chloride as a preservative material that's used in the bottle. So because that's one of the causes of sometimes of the inflammation and allergy. That's why we are pushing our patient to have a preservative-free tears or content.
I think maybe he's not aware about preservative. Preservative, most of the medication we are using before, there was a material that also, in addition to the acting agents, to make the preservative for a long period of time or something like that. The new molecule that they are using only the acting agents without any material added to that. That's what we mean by preservative-free. Another question: what's the relation between conjunctival chalesis and dry eye?
Conjunctival what? Sorry.
Conjunctival chalesis.
Conjunctival chalesis.
Yeah.
So conjunctival chalesis is a condition where you have a redundant or extra fold of the conjunctiva.
Yeah.
So what happens is these patients usually have an overfold of the conjunctiva. So it's best seen on slit lamp when the patient is looking in a primary position. And most of these patients require an excision. So they require localized excision of the conjunctiva.
Most of the conjunctival chalesis, we are seeing them after the plastic surgery, and at least that's what I'm seeing. But most of them, they will not have the dry eye because it's only acquired after the plastic surgery.
I mean, there is no relationship between dry eye and conjunctival.
So I'm not sure that there is any relationship between the
I think most of the patients presented watering actually, because if the conjunctival chalesis is in the nasal quadrant,
before more than dry eye.
Yeah, if the conjunctival chalesis is in the nasal quadrant, it causes an occlusion of the puncta.
Okay, last question we can go through is there an non-steroidal anti-inflammatory eye drops? Is there any place for the treatment of dry eye?
No, none. That's what I feel, yeah.
Sorry?
I do not have nothing that I would consider as a treatment or to help in dry eye.
No, it's not considered.
Okay,
it's one of the causes of the dry eye. So it might initiate sometimes with its preservative as a dry eye.
Okay. Anyway, thank you very much for this discussion. So we can move now to a next part of our session today. And we'll have my dear friend, Dr. Bassen. He will give a talk about peripheral retinal dystrophies as part of episode 6 of MIOM, Master Medical Retina from A to Z. Dr. Bassen.
So are my slides visible?
Yes.
Yeah, it's clear.
Thank you very much, Dr. Amri and the MIOM Academy for giving me an opportunity to speak. So I'll be speaking on peripheral retinal dystrophy. As you are aware, this is an extensive topic, and it's also a very dry topic because in the medical school, we are expected to answer a few questions pertaining to this. And in clinical practice also, we don't, many of the medical retina guys or the surgical retina guys don't usually concentrate much on this disease because there's not much of treatment options available. So I would like to look at this condition from a clinical perspective and see what are the clinical points you can take from peripheral retinal dystrophy. So before I start my talk, I would like you to go to the entire list of hereditary corneal retinal dystrophy. So this is an extensive list, right from diseases involving the vitreoretinopathy, inner retinal layers, the vascular complexes. The extensive list just keeps going on. And you can have some overlapping diseases between this. Like, for example, you'll have mitochondrial disorders such as Kearns-Sayre Syndrome, which is a part of the syndromic retinitis pigmentosa as well. So in the next few slides, I'll be actually concentrating on these 4 things. Retinitis pigmentosa, which is a generalized rod cone dystrophy, the non-syndromic retinitis pigmentosa, the syndromic ones, and a few of the mitochondrial disorders. And why I'm doing this is because this is the most common presentation which comes to us. So the rest of them are pretty rare in this part of the world. The common ones are retinitis pigmentosa and some of the syndromes associated with this. So having put this stage set on discussing these few points, let's start with talking about retinitis pigmentosa. So as we are aware, this is a heterogeneous group of disorders which are characterized by night blindness. And they also have a progressive visual field loss due to photoreceptor and RP dysfunction. And most of these patients have an abnormal ERG finding. The prevalence of this disease is 1 in 4,000 to 1 in 7,000 population. And the important thing we need to remember is this is an abnormality both of the rods and the cones, but the rods are affected more than the cones. So in short, this is a predominantly a rod disease with the involvement of cone problems. The clinical features and signs are very characteristic. So the symptoms are bilateral involvement, but this can be asymmetric. The patients have loss of peripheral vision first, and more importantly, they have night blindness. And we know the classic triad of RP. You have these bony spicule pigmentation, which are basically intraretinal migration of the retinal pigment epithelium, and they get deposited around the vessels. So this is the classic appearance of a bone spicule pigmentation. You have arteriolar attenuation, which is the earliest feature. This can occur even before the presence of bony spicules. And waxy disc pallor, which is the least reliable feature. So for example, here you may not appreciate waxy disc pallor in this patient, but you know this patient has classic retinitis pigmentosa. You can also see some macular involvement, and we need to know about the macular involvement because this is the commonest cause of loss of central vision. We know that RP patients lose the peripheral vision, but they can lose vision due to central causes. And these are cystoid macular edema, epiretinal membranes, and atrophic degeneration. Rarely you have patients who also develop a macular hole. Now, why I'm signifying this is because if you see your RP patients who come with cystoid macular edema and we do their OCT, you find cystoid macular edema, these are treatable causes, similar to epiretinal membrane. So if a patient comes with an epiretinal membrane or a macular hole, these patients can undergo surgery and they can benefit from the surgery and from the treatment of macular edema. So you can salvage some central vision because they are going to lose the peripheral vision because of the disease. So if you look at the ocular investigations, in the past, we used to do a lot of fluorescein angiogram on these patients, and you would find this diffuse hyperfluorescence or a stippled hyperfluorescence in the mid-periphery. Also, you might notice some changes in the macular area and some cystoid changes. However, in view of exposure to light, we've stopped doing fundus fluorescein angiograms for these patients, but we rely on fundus autofluorescence. Now, this is an autofluorescence image of a patient with retinitis pigmentosa. And I would want you to bring to attention this classic hyperfluorescent ring, which is associated around the macula. This is known as Robson-Holler's ring, and this has a clinical significance. Why it has a clinical significance? Because as the severity of the disease progresses, this ring starts becoming smaller and smaller. So if the patients don't want to undergo visual fields or ERGs or any further investigations, then this you can just do an autofluorescence and judge whether this ring is becoming smaller and smaller, and that would indicate the severity of disease. We also note that this is the retina which has preserved function. So if a patient has preserved function, if this ring becomes smaller, the visual field also becomes smaller. So this is the clinical significance of this. It's known as an RH ring, Robson-Holler's ring, and that's how we look at doing autofluorescence in patients with retinitis pigmentosa. We also do visual fields in these patients because we know that in certain patients, the visual field defects would start in the superior quadrant. Why is that? Because RP in majority of the patients will start in the inferior quadrant. So these patients have visual field defects between 20 and 40 degrees. And this is again of clinical importance because sometimes you may not notice any pigment in the retinitis pigmentosa patient, and they can have these visual field defects. ERG, again, the amplitudes are markedly subnormal in early cases. Both the A and B wave are affected. So you can look at this scotopic red, you see an absence of the A and the B, and this becomes lesser and lesser. Same is scotopic white, you see an absence of the A wave. In patients who have extensive RP or end-stage RP, they have extinguished ERGs. And this is important because we would like to differentiate certain conditions based on the ERG results. The classification, ideally, the classification should be based on molecular and biochemical abnormalities. So currently, the classification is based on gene definition. So genetic abnormalities are now being used to define the disease. but we can base it on inheritance types like autosomal recessive, which is present in about 50 to 60% of the patient, autosomal dominant in another 30 and 40, and X-linked RP, which is 10 to 15% of the patients. We also look at mitochondrial inheritance, which is associated with pigmentary retinopathy. I would here like to stress simplex RP. Now, what is simplex RP? These are patients who come to you to the clinic, but they don't have a family history, but they have classic findings of RP. So these patients are known as simplex cases. That means you don't have a family history. None of the family members have retinitis pigmentosa. This is seen in about 15 to 63% of the patients. The age of onset is also important because this can be determined by the timing of the blindness and nystagmus. Now, we all know the 2-4-6 rule of nystagmus. So if a child has poor vision less than 2 years, they will have nystagmus. If the blindness or the visual loss occurs at the age of 4 or less, they may or may not have nystagmus. And if the visual loss is after the age of 6 years, then nystagmus is never present. So this is a very simple way to judge. If a patient has nystagmus, you can judge when the visual field or the problem started happening. So that's another clinical tip for you. So this is congenital, or it can be childhood onset. The first 3 decades of life are very important because that's the time juvenile onset or early onset RP occurs. The classification also can be based on retinal involvement or the fundus appearance. So as I mentioned, there's a condition known as retinitis pigmentosa. So this is RP without intraretinal pigmentation. These patients just have arterial attenuation sometimes, and they complain of night blindness and peripheral visual loss. So when you do a visual field, you'll see the defects between 20 to 40 degrees in these patients. Sector RP or sectorial RP, here the pigmentary changes are limited to 1 or 2 quadrants. And the visual field defects also in the similar area. For example, here the patient has an inferior defect, so you see a visual field loss at the top in these patients. And they have relatively good ERG response and a minimal extension of retinal involvement. So if you see them over a period of time, this area just remains the same, and they have a good prognosis. These can be autosomal dominant or recessive. Pericentral RP, on the other hand, the visual loss occurs between 5 to 15 degrees. Now, if you remember what I mentioned, the visual loss is classically in 20 to 40 degrees in patients with classic RP. Patients who have pericentral RP, because it's closer to the center, they have 5 to 15 degree visual loss. And that's the reason they get early central involvement. So they have greater disability early in life. This can again be autosomal dominant and recessive. Unilateral or extremely asymmetric RP, we have to always keep a watch. If the patient has unilateral signs of RP, you want to look at other causes of retinitis pigmentosa. So what is atypical RP? Atypical RP, one of the 2 things is retinitis punctata albicans. So this is again autosomal recessive or dominant. So instead of seeing bone specules, you actually see yellowish white dots, which are more numerous at the equator, and importantly, they spare the macula. But these patients can have arterial attenuation, night vision problems, and progressive visual loss. Eventually, finally, what happens over a period of time, the retinal findings start replacing the retinitis pigmentosa cases. We need to differentiate this condition from fundus albipunctatus because in albipunctatus, they have similar yellowish white dots, but they're smaller closer to the posterior pole. And as you go peripherally, those spots will become larger. Whereas here in retinitis pigmenta albicans, they are all uniform in color, uniform in size. Coats like RP, this is also known as angiomatous proliferation, where 3.6% of these cases can have vasculopathy. They can have retinal telangiectasia like this. They can have lipid deposition in the periphery, peripheral ischemia noted on the angiograms, and sometimes they can have neovascularization and serious detachment. These eyes require laser cryotherapy and sometimes even anti-VEGF treatment. Eventually, some of these patients might present as vasoproliferative tumors of the secondary variety. Now, I remember a case presented by our colleague, Dr. Amr Farid, sometime back, maybe 6 months or a year back, where he showed all these cases in a patient with retinitis pigmentosa, and all these features were present. So this is that indicates that this may not be a very rare condition. We might encounter this in our clinical practice. What is a systemic association? And so these are known as syndromic RPs. Patients with RP have one important tip is to remember they have greater than normal risk of thyroid disease. So if patients come to you with RP, 7% of them might have mild thyroid problems and 3% might have severe thyroid issues. So you also want to check for thyroid problems in patients with retinitis pigmentosa. So when you see patients of retinitis pigmentosa, hearing loss is the first thing you want to check, because about 30% of these patients might have hearing loss, and this will clinch the diagnosis of 2 conditions, Usher's and Refsum's disease, which I'll describe later. We also want to look at metabolic disorders, If the patient has neurological problems, it will clinch the diagnosis for Bassen Kornzweig, Refsum, and Kearns-Sayre Syndrome. We want to look at the renal and the hepatic disorders because some conditions they can present with renal problems and eventually die because of that. Some patients can also have hepatic fibrosis. And also you want to look at certain cardiac issues, so whether they have arrhythmias or other things. So Kearns-Sayre syndrome. So essentially RP can be associated with various systemic problems, and there are various syndromes which are associated with them. So let's try and look at each of them, and I'll tell you the reason why you want to do that. Usher syndrome, the key features I want you to remember is deafness, ataxia, and neurological abnormalities. Now, there are three types of Ushers. I don't want to go in detail. So what happens is these children develop in a very young age sensorineural deference, and we know that hearing is a very important thing for speech. And because this deafness is so profound, they also have speech problems when this condition occurs in childhood. Because the ear is also associated with vestibular function, these patients will have ataxia, and they also have neurological abnormalities, in addition to the various retinopathy conditions. Now, the important thing we need to know is all children with profound deafness should be screened for Ushers. So this is an important thing which you want to convey to your neonatologist, the pediatricians and the pediatric neurologists. And why is it important? Because if you diagnose them early, then doing a cochlear implant is going to make a big change of in their life. Their quality of life is going to improve significantly because they can start hearing, they can start seeing, and they can start talking because, as you know, speech development requires hearing. A differential diagnosis is rubella retinopathy. So if you see patients with deafness or ear problems and this kind of a retina picture, we want to label it as rubella retinopathy. Now, it's a crime to do that because if you miss a patient with Usher syndrome, you're going to miss the opportunity to treat these patients with a cochlear implant. And the only way, one of the ways to differentiate is if you do an ERG, the ERG is essentially normal in patients with rubella, unlike Usher syndrome. Bardet-Biedl syndrome, there are some key features: retinopathy, mental retardation, obesity, hypogenitalism, and polydactyly. So when you see children who got RP, you also want to quickly look at the fingers and the toes to see whether they have polydactyly. Sometimes the parent may not come with the answer of saying that, yes, probably they have had some surgery to correct the extra fingers or anything. So basically you can ask these parents whether they have these problems, and especially try to look at obesity as well, Bardet-Biedl syndrome. So these are the various ways they will present. An obese child, they can get an extra finger. Okay, they can get some dental problems, and here's some scarring present here. These patients can also present with bullseye maculopathy. So that's one of the differential diagnoses of bullseye maculopathy. In the past, when we used to read the whole term Bardet-Biedl syndrome. But nowadays, this is considered a part of the same spectrum. So if the patient has any of these four features, it's considered as BBS syndrome. Okay. The features of retinopathy are, it can present as RP sign pigmento or retinitis punctata albicans, or as I mentioned, bullseye maculopathy. So this is one of the differentials of bullseye. Here, it's important for us to pick this up because these patients eventually develop kidney problem, hepatic fibrosis, and cardiac problems. And you want them to be seen by the pediatric nephrologist because eventually they might land up with a kidney failure and die. So if this is picked up early, you can save these patients from having an early death. So these are the significant clinical associations. Bassen Kornzweig is a syndrome of 3 A's: ataxia, acanthocytosis, and A-beta lipoproteinemia. So it's a condition where there's an abnormality in the lipoprotein metabolism. And because lipoprotein is very important for fat absorption and the fat-soluble vitamins, all these patients will have deficiency in that. And also you get red blood cell abnormalities. So these patients will have intestinal lipid malabsorption. That's the reason, because lipids are low, you have low serum cholesterol levels. And we know that A, D, E, and K are the 4 vitamins which require fat. So they are fat-soluble vitamins. So these also get deficient. You have absent plasma beta lipoproteins. Eventually, because there is low fat, we know cholesterol is very important for in the neural tissue. They get neuropathies and spinal cerebral ataxias. The retinopathy types are retinitis pigmentosa, typical RP. Now, another important thing is if you see a patient who's got RP with certain features of this, you're clinching a diagnosis of Bassen Kornzweig syndrome. So other conditions where RP is present is pseudoxanthoma elasticum, Ehlers-Danlos syndrome, etc. So those are also to keep a watch out for. How do you treat? low fat diet and a large dose of fat soluble vitamins like A, E, K are known to control this disease under control, bring it under control. Refsum disease is a disease of 3 Ps, where you have phytanic acid metabolic deficiency. And this phytanic acid is responsible for some peripheral changes in the neuropathies. They can also have palpitations and cardiac arrhythmias and cardiac myopathies. Again, Refsum disease, as I told you, can be associated with sensory neural loss, meiosis, anosmia. And another important tip here is the fourth toe riding on the dorsum of the foot. And these patients will have short, stubby thumbs and irregular asymmetric length of both toes. So if you look at the feet here, you can see this fourth toe which is overriding. Sometimes it might be overriding here on the side as well. So it can be present in both the feet. And so that's the reason to look at the fingers and toes. So fingers for polydactyly and toes for this epiphyseal dysplasia in patients with RP. The retinopathy is classical like an RP patient. If you do a plasma phytanic acid level, this is usually 0.4 to 4 milligrams. So these patients will have raised levels of phytanic acid, and low phytanic acid diet or plasmapheresis is recommended. Kearns-Sayre is a condition where you have ptosis, chronic progressive external ophthalmoplegia, and heart blocks. So these patients will present with cerebellar syndromes, weakness in the extremities, progressive hearing loss, and short stature. So if you find a patient with RP with ptosis, okay, you're looking at a patient who's got Kearns-Sayre syndrome. And also they might have chronic progressive external ophthalmoplegia. So a lot of this diagnosis can be made just most of the time on clinical examination. And the important thing is these patients will be present before the age of 20 years with ptosis being the first complaint. They may not complain to you with symptoms of night blindness, but rather ptosis. Retinopathy is like salt pepper retinopathy. So you can see this diffuse salt pepper retinopathy present. Diagnosis is when you do a skeletal muscle biopsy, because these have abnormal mitochondria. So they have mitochondrial deficiencies causing pigmentary retinopathy. Let's look at the differential diagnosis of retinitis pigmentosa, or these are known as pseudo RP. So these can be unilateral or bilateral. So drugs like theoradizine. Theoradizine is a very, a classic drug where initially the toxicity looks like RP, and in the late stages, the toxicity will look like choroideremia. Chlorpromazine can also cause problems. Chloroquine and hydroxychloroquine can cause bullseye maculopathy, and quinine can also cause problems. Infections like rubella retinopathy, I mentioned that ERG will be normal here, but they have similar features of RP with hearing loss. Syphilis is another condition which can affect the retina and cause RP-like changes. Measles, and a condition known as Duchenne. So Duchenne is basically caused by worms. So it is defined as diffuse unilateral subacute neuroretinitis. The classical term, the worm which causes the problem is raccoon nematode. And one of the ways to find is to search for the worm. And once you find it, to either treat it with laser or vitrectomy. And if these patients have vitritis, you give them anti-helminthic medications. Scarring in the retina can be because of various problems like chronic CSE, laser, trauma, retinal detachment. VKH in the late stages can look like RP. Even resolved UV effusions can look like RP. Vascular problems, basically anything involving the choroidal circulation or the central retinal artery occlusion in late stages can look like RP. Autoimmune retinopathy, actually here the fundi are practically normal. So if you have an adult patient who has development of night blindness or have shimmering lights in front, and they have progressive drop in the visual field, and if you look at the fundus and it appears normal, you're probably looking at cancer-associated retinopathy or melanoma-associated retinopathy. And cancer-associated retinopathy has usually the ARGs will be extinguished, and melanoma-associated retinopathy, they have something known as an electronegative ERG. ERG is a total different topic. We can probably discuss that later. And nutrition, most important, vitamin A deficiency can also present with night blindness and look like pseudo RP. And these are treatable causes of RP. So a quick last two slides on workup of a patient with night blindness. You look at the medical and the ocular history pertaining to the diseases which I previously mentioned. You look at a drug history, whether they are on any drugs, a family history with pedigree and genetic testing for diagnostic purpose. And you also want to check whether there is history of consanguineous marriage for autosomal recessive conditions. A good ophthalmic examination right from the anterior segment to look for keratoconus, cataract, primary open-angle glaucoma, because all these are treatable causes. And systemic evaluation, look at the fingers, toes, look at obesity, hearing aid. My spelling of obesity is wrong twice, so I need to do a spell check here. hearing aids, whether they have hearing problems or ptosis. A formal visual field testing is important. Dark adaptation, we don't have facilities, but ERG, because this helps to differentiate the various causes of night blindness, like congenital stationary night blindness versus other dysfunctional forms of RP, which are progressive in nature. A fundus photograph is important. Consider doing a syphilis test, especially an FTA-ABS or TPHA to rule out pseudo RP. If there's a male patient and the inheritance is known, then examine the mother and perform an ERG, because the mother might be a carrier of X-linked RP and she might have abnormalities. If there is neurological abnormalities like ataxia, polyneuropathy, some deafness, obtain a serum phytanic acid level to rule out Refsum's disease. If there is hereditary A beta lipoproteinemia, obtain a serum cholesterol level, triglyceride levels, which are usually on the lower side. And these patients can also have acanthosis on peripheral blood smear. Kearns-Sayre syndrome, very important, because you can protect or save these patients from cardiac events by doing sequential ECGs, and the patients can drive for complete heart block. And very, very important, examine all the family members of RP, because that's the only way to pick up syndromic RPs or RPs which are genetically hereditary. So thank you very much for the kind attention, and I'm open to any questions.
Thank you very much, Prasan. An excellent presentation as usual. Even we get lost with lot of names, you know. You are not all the times, you know, find this one, but you need to keep in mind in case. Okay, so if there is any comment, Dr. Ahmed, or questions?
It is an excellent presentation. It's covering everything, and I enjoyed it. Thank you very much, Prasan. Yes, we are not facing those kind of dystrophies regularly, the Refsum especially, and the Kearns-Sayre and so on. But we need to keep them in mind because we have a lot of patients with retinitis pigmentosa, and genetic testing is one of very important to be done for all of those patients. We hope to have a gene therapy soon. We have for the RPE65. We hope for others to follow. Yes, we need to do genetic testing for those patients. And I agree with you totally for the investigations for such patients. The visual field, at least initially. Autofluorescence definitely plays an important role. No room for fluorescein angiography anymore. And I cannot emphasize enough on your elaborative and excellent presentation.
Thank you very much, Ahmed. Dr. Safwan?
Well, I was interested to highlight the Usher Syndrome, and Prasant, he described it in an excellent way. We had a group of patients that in our country having the Usher syndrome with the retinitis pigmentosa, and we were doing the systemic investigation part from those that they have the deafness, and sometimes they are not presenting with the full deafness. They might have a partial and but a weak, so they have the aids for the hearing. And once they are coming to our clinic, we know that it's a retinitis pigmentosa, because mostly you will see that the hearing aids, and with their age, and accordingly now I'm seeing even from the same area in our country, they are coming, and most of them definitely we know them that they are autosomal dominant or recessive, because they may reach to up to 40 or 50, and they still having a navigational gaze, or they have 0.1 or 0.2 vision, but they have hearing defect. And that's one of the issues that I need to comment it. It's an important issue for our ophthalmologists to know that there is an association, systemic association with retinitis pigmentosa. And he explained it in a very excellent way.
I just wanted to ask Prasan, what do how in these cases of retinitis pigmentosa with cystoid macular edema, how do you treat those?
Especially after cataract surgery. Yani if we can add for them for what Dr. Ahmed said, especially when they have cataract and we need to do the cataract surgery for them, and especially we will have after that a persistent cystoid macular edema.
Yeah, so let's take the disease in one at a time. No? Okay, so the patients with RP can present with cystoid macular edema. So the way you treat those is the primary aim is to give them carbonic anhydrase inhibitors. So either they can be in the form of topical or systemic medications. So topical dorzolamide is supposed to have very good effect. And also you can use oral acetazolamide. Sometimes they require it for a long period of time. So acetazolamide you might have to end up giving for about 3-4 months. And because it's an oral medication, you need to make sure that the potassium levels are monitored. You give them a dose of 500 milligram and you can use it, step it up depending on how the patient responds. The other option to treat them is by using, there are articles where they have injected these patients with steroids, like triamcinolone and dexamethasone implants. Yeah. So these are the ones we can use, but we need to bear in mind that, you know, they may or may not be effective.
Yeah.
If they're effective, then they generally require multiple injections of these medications. And we already know that these eyes are prone to develop cataract because they might have some cataract to present with. So it would be just making the condition more worse for the patient. And eventually they might land up with cataract surgery. There are some articles of using anti-VEGF agents for cystoid macular edema, but there are a lot of authors and a lot of scientists who say that you should not use anti-VEGF for treating cystoid macular edema in patients with hereditary or RP. And the reason we want to do that is because already these patients have compromised vascularity.
Yes.
So already they have arterial attenuation, so anti-VEGF should not be given. And secondly, VEGF in these eyes might have some neuroprotective effect. And chronic neuroprotective effect blockade by the anti-VEGF drugs can cause rapid progression of the retinitis pigmentosa in these patients. So 3 options which you can do is topical carbonic anhydrase inhibitors, oral carbonic anhydrase inhibitors, or intravitreal steroids in any combination. I've tried posterior subtenons first for some patients. It did work in 1 patient out of 4 patients. And that 1 patient fortunately kept responding to the posterior subtenons. So you can try posterior subtenons also, because they might have some. I was reluctant to give them triamcinolone intravitreal because it's not approved in this part of the world. Whereas you can give posterior subtenons. The only thing is if the pressure starts rising, you have an option of removing the posterior subtenons from the subtenon space.
I agree with you totally.
Yeah,
about
we need to put in our mind that that the glaucoma is part of those patients.
Absolutely.
They have a high level of glaucoma, cystoid, attenuated vessels, and waxy disc appearance. So from this point of view, anti-VEGF, as you said, it might lead to a very quick progression of the vision, especially to the central part, and that's why I'm not sure that anti-VEGF have a rule, because there is a lot of articles shows that the progression of the reduced vision was very quickly after the anti-VEGF. Now, steroid, as we know that the steroid can lead to glaucoma, even subtenons. In my opinion, that when I'm starting the topical, because I know that this is a chronic topical carbonic anhydrase, but unfortunately the COSOP can create some corneal changes in.
You actually have to use dorzolamide, Trusopt.
Trusopt.
Yeah.
Trusopt.
And Trusopt, yeah.
Yeah.
And the other thing, important point what Dr. Safwan mentioned is the presence of glaucoma. Now, most of these RP patients have 2 problems which you can treat, and that's one of the reasons you have to keep asking the patients to come for follow-up. One is cataract, and the second is glaucoma. But the problem with glaucoma is it's very difficult to monitor the glaucoma because the visual fields are already compromised.
Yes.
So you have to rely only on the disc, and you have to rely on your intraocular pressure readings and RNFL levels, if it's possible, to monitor your visual fields. Patients with autosomal recessive BEST can actually present with narrow angle glaucoma. So this is another important thing we need to remember.
Yeah. So what I'm saying is that non-steroidal anti-inflammatory as a long-term therapy for those, it might, in your opinion, not affecting, but really
you
just
can try it. You can try it, but it doesn't work actually. There are a lot of articles which say there's no role for those.
Anyway,
Dr. Ahmed.
I agree totally with what Prasan mentioned and Safwan. So I had a lot of, and still have a lot of patients with retinitis pigmentosa with having cystoid macular edema. So systemic carbonic anhydrase inhibitor sometimes is effective and sometimes does not do anything. And with its systemic complications, some patients do not even accept these type of complications, especially if they are diabetic and with some renal issues.
Neural problems.
So I usually depend on topical dorzolamide Trusop in those cases for a long time, but sometimes they do not respond as well. Exactly. So I tried anti-VEGF with different molecules, and it is not just harmful. I would not say that, but I would say that it is not effective. So I didn't find anything that can be effective except steroids. And I agree with Prasan. You can start with Subtenon. Sometimes it works. And if it does not, then I would go for implantable injections like the Ozurdex rather than triamcinolone intraocular. I only use it for during vitrectomy for staining, and then I wash it all out. Because of risk of endophthalmitis, risk of complications, which is higher with triamcinolone rather than Ozurdex, for example.
So there are actually there are 3 questions there.
Yeah, that's why I'm going to.
Dr. Ashraf.
Yeah, there is a comment, so we will go one by one, and then we have a comment from all of you. Dr. Ashraf Awada, he said nystagmus is usually not associated with RB because the disease gradually starts with more in-road peripheral than very late affect some cones.
Dr. Ashraf, actually there is a condition known as Leber's congenital amaurosis, which is a part of the RP spectrum. It's usually an autosomal recessive variant. So these patients may actually have very poor vision at birth. So they have abnormal pupillary reflex. The fundus might appear to be normal. They have hyperopic refraction. And the vision is so poor that they keep having this ocular digital syndrome, which is very common. You see these kids keep on pressing the eyes. Yeah. And the reason is because the vision is so poor, they keep pressing the eyes because it helps to stimulate the retina and produces some sort of an image. These light stimulus. Yes. So that is classic. When you see a child who's just pressing the eye, this is classic for Leber's congenital amaurosis. Yeah. And these patients can actually present with nystagmus. So we don't say that nystagmus is usually not associated. If nystagmus is associated with RP, it's a very severe form of RP, which usually presents in childhood. Leber's congenital amaurosis, one of the gene, there are 23 genes which are associated with Leber's. One of the important gene is RP65. And as Dr. Ahmed mentioned, we have gene treatment for that. And the name of the medicine is Lexterna, which was approved by the FDA in November 2019, I think. And it's being done in UAE. So they have treated about 5 or 6 patients of RP65 abnormality at Cleveland Clinic. And they require subretinal injection of the gene therapy. And they have splendid responses or amazing responses after the procedure has been done.
I think there is another comment, but actually we have go through all that. But are there a unilateral RB? I think you have already mentioned that, Doctor. You go through that.
Yeah, it's mostly defined as pseudo RP.
Yeah. There is also a comment about vitamin A to give it daily, so it will have a benefit for that. Also, this one also you go through. What are the best choice for anti-VEGF for RP?
I will not recommend. I will not recommend
that. Even though there is one study done, I do remember it is done. A lot of cases done in Jordan, and he's having a paper about that. But as you mentioned, it is so many other came up with not suggesting to give anti-VEGF.
There was some initial reports, but nowadays I don't think that there is anybody who's recommending any type of anti-VEGF.
Progression is very high, so I mean, no one can have this risk.
The thing about vitamin A 1,500 international units, this is a very good thought about this, but the problem is when you give vitamin A 15,000 units as a supplement, you have to be very, very careful because this high dose of vitamin A can have hepatic toxicity. Yeah. And especially in patients who have pre-existing hepatic problems, like with a lot of those syndromes have hepatic problems, you don't want to give vitamin A. It's more experimental and it was tried. And the other problem is a lot of these patients can develop lung cancer if they have history of smoking. So it's advisable not to give vitamin A for patients with RP.
I think, Doctor, this one we have to treat the patient with another subspecialties. I mean, we have to refer to different subspecialties to be part of the treatment. So vitamins and all this one, it shouldn't be, I mean, be judged only by ophthalmology itself. So there is a test that should be done also by medical and other things for hepatic, renal, and all the others. There is also Dr. Muhammad Abdullah is with us. If you are still there, Dr. Muhammad, and you want to be with us in the panel, you can raise hand and you can open for you. He's also saying hello to everyone. And he's have just one point I would like to add is that cystoid macular edema in retinitis pigmentosa in many cases may not be leaking on fluorescein angiography, unlike the CME post-cataract surgery. This could be a differential point, and thanks. I think this is another.
I think maybe he's replying to Safwan when he was talking about the post-cataract surgery in retinitis pigmentosa.
Yeah, but I'm seeing them that it's more, yani, after cataract surgery, that cystic macular edema, it's progress more than pre-op. So that's why I'm saying, yani, whether we need to treat it or not. But for me personally, I'm treating them.
You have to treat them. You have to treat them.
We have to.
Okay, just if you allow me, all my colleagues, attendees, they can now in the chat. You will find the link for certificate of attendance, so you can just download there, please. And also, I want the team, if you can put an email for anyone who couldn't, he can just send you an email and you can send back to him the certificate of attendance. Is there any other comments from any one of you? There is one more question came, and maybe this one. Even CME, no leakage, need treatment.
Yes.
An opinion of this one already mentioned by all of us here. Yes. Okay. I'd like at the end of this session, I don't anticipate to continue that much, but it was a very nice, as usual, interesting discussing whenever the Dr. Safwan and Dr. Ahmad Prasan. So you cannot, I mean, you are enjoying all the talks or discussions, get a lot of benefit. Thanks for Prasan for an excellent presentation. Thanks Dr. Safwan and Ahmad for an excellent comment and answering and debate also about all the points that highlighted. Thanks for Jamjoom for sponsoring this meeting. And thanks for management event. Thanks Muhammad Shui, he was with us. If you want to say something, Muhammad, we are here. Just the last.
Thank you, Dr. Muhammad. Thank you, Dr. Safwan. Thank you, Dr. Ahmed. Thank you, Dr. Prasan, for illustrative lecture. I enjoyed a lot. And waiting for more, inshallah. Thank you a lot.
Thank you.
Thank you very much, and have a nice
night.
Not night. Tomorrow, a working day.
One
working day. Okay.
One last point before I leave.
Yeah.
RP patients also have dry eye.
Yeah.
Thank you, Muhammad, for your presentation as well.
Yes.
And for your great
Thank you for all of you. Thank you.
Thank you. Thanks.
Bye-bye. Bye-bye.
Good night.
Good night.